Elbow stiffness is a very common problem following elbow trauma or even elbow surgery. When conservative management fails, what usually happens generally after 6 months, open release have been historically indicated with various results. Much more recently, arthroscopic release has shown to be a very interesting tool to deal with such problems, and better results are being reached every time. This case is a very nice example of how useful arthroscopy can be in such cases. So this case is about a 46-year-old old man who had a fracture in his left elbow when he had only 6 years old and developed stiffness just a couple months after that trauma. Since then, his left elbow had full flexion, but his extension became very limited since he could not extend his left elbow more than 90 degrees. As he grown up, he had to adapt to such situation, and in the last 10 years, 3 different doctors had said that his left elbow stiffness would never have a good solution. He didn't have pain, but since he could extend his elbow only till 90 degrees, his left hand was much less used than it really should be. This patient came to me 1 year ago with an AC, advanced degenerative condition in his right shoulder, and in January 2010 we performed an arthroscopic Mumford and arthroscopic distal clavicle resection in his right shoulder, and he had a very fast and good recovery. And then I told him that we could investigate his left elbow stiffness and that perhaps we could release it arthroscopically. Initially, we asked for some x-rays. This is a plain lateral view in full flexion of his left elbow, as we are seeing now, in which we can see no bony problems. And this is the lateral view in full extension, in which there is no evidence of any kind of bony problems too. We asked for some CT scans, and the CT scans revealed a quite preserved bony anatomy. This is the lateral view, in which we can see the lateral column, and this one is the front view, in which we can see a quite normal distal humerus bony anatomy, and this is the medial view, in which we can see a quite normal humeral joint. An MRI is a very important exam in this case, because such a patient should not have arthritis if we think of releasing this elbow. It's very important to say that once a patient has a stiff elbow and arthritis, he doesn't have pain only because his elbow doesn't move. Once the elbow starts to move, pain will surely come due to previous arthritis. In this image, we can see that the distal humerus cartilage was incredibly intact. And in this image, we can see that not only the distal humerus cartilage was in nice shape, but the radial head cartilage was in good shape too. In the lateral view, still in the MRI, it's very clear that the radial head was definitely deformed and that the anterior capsule was intensely retracted. After discussing this case with a lot of care, we decided to perform an arthroscopic release of this left elbow. So this is his arthroscopy, a very thick capsule. This is a left elbow. We started working for the lateral portal, releasing all the very thick anterior capsule he had. Now we are seeing in the upper part the capitulum and below the radial head. We are removing the lateral parts of the anterior capsule with a shaver, taking a lot of care not to damage the interosseous nerve, and now taking the capsule even with a basket or with a soft tissue shaver, still working for the lateral portal. Now we are working for the medial portal, releasing the anterior capsule until we found the brachialis tendon. And now we are still releasing the soft tissue. Now we have already found the brachialis tendon. This is the brachialis tendon, and we are working to see the coronoid. This is the brachialis tendon, and now we are just about to see the tip of the coronoid process. This is the tip of the coronoid. We are flexing the elbow, but still we were unable to extend the elbow. This is the tip of the coronoid, and at that moment, so we decided to switch the portals again and to perform a full resection of the radial head. Now we are starting for the lateral portal to resect all of the radial head, and once the radial head would be fully resected, we could resect a little part of the capitulum if necessary, and it was. So now we are taking a little part of the capitulum in order to make resection of the radial head easier, and still removing a lot of bone since we were doing it arthroscopically. We had to pronate and supinate the forearm, as we are seeing now, to make resection easier. And then we had to establish an alternative portal, as we are seeing now, in order to achieve a full resection of the radial head. This is a more posterior portal, a very safe portal, and then through this alternative portal we could achieve all of the parts of the radial head. Now we are finishing the radial head resection and using a soft tissue shaver. This is the final part of the resection, still working for the new lateral portal. Now the radial head resection was almost finished, and now we are seeing the semilunar fossa for the lateral portal. After surgery, the patient used an articulated orthesis like this one showed here for about 6 weeks, 24 hours a day, moving from forced flexion to forced extension every 6 hours. He started physical therapy about 2 weeks after surgery, and now he has 3 months of surgery since he was operated in July the 2nd, 2010. He has already gained almost full flexion, but we are not really worried about that, since he never had problems with flexion. He has already reached 25 degrees of extension, and as we are seeing now, what means that in only 3 months he gained amazing 65 degrees of extension of his left elbow. He will keep physical therapy for more 3 months, but he says that by now he's fully satisfied with his result. In this photo, we can see that he already has full supination in his forearm, and in this another image, we can see that he already has gained full pronation too. So this case is an interesting example of how useful arthroscopy can be, and that better outcomes can be achieved with minimum tissue destruction and faster recoveries. Thank you.